Okay, well, welcome everyone to Pediatric Teaching today. Today I wanted to talk about respiratory support that goes beyond oxygen, and I particularly wanted to talk about CPAP and high flow, humidified high flow nasal prong oxygen therapy. And the reason to talk about them is you. I think my phone keeps going off. Sorry. Yeah, we'll start again, eh? Yeah, the reason to talk about CPAP and high flow is that there's new availability of these devices or devices to give CPAP and to give high flow respiratory support in many countries, including in Papua New Guinea and the Pacific. Other Pacific countries, and I wanted to just try to describe some of the devices that are available to provide CPAP and high flow respiratory support, and to describe their indications and have a discussion about how to go about it and how to troubleshoot and what complications to look for, etc., etc. So the aim is to explain how CPAP and high flow works, both the clinical and the technical reasons they work, and to describe the different types of CPAP and high flow. Most of the CPAP and the high flow I'll be talking about are using devices that are available in Papua New Guinea at the moment. There are many other devices available to give CPAP and several others to give high flow, but I won't be talking too much about those. But the general concepts that relate to CPAP and high flow apply. Well, the most important thing I want to say is that even before you think about CPAP or high flow in any sick child or any sick neonate, then oxygen is most effective in most occasions. And so 80% of all children with pneumonia, for example, they just need standard flow oxygen or they need a bit more oxygen. I just wanted to show you a video before we start talking about CPAP about how effective oxygen is. And this is a video of a small baby who this little girl had pneumonia. And I just want you to look at the video and you'll see that she's awake and a bit distressed. And then oxygen saturation, if you can see that, goes down to 52, 51, and then she becomes quite sleepy, and she falls off to sleep. And you keep watching the video. She falls off to sleep. Her saturation goes below 49%. So she's very, very hypoxic at this point in time. And one might imagine that this sort of child would need some high level of respiratory support. She might need, intubation or mechanical ventilation. But I just want you to see what happens. This is a minute later, 1 minute later. Her oxygen saturation is now 98%, and she's now alert and she's awake. And she had fallen asleep or become less conscious because of her hypoxemia. But and you can see what she's got is nasal prong. She didn't need to have CPAP or high flow or mechanical ventilation. In fact, all she needed was this. So I'll just show you the third video. You can see what she's got, about between half and 1 litre per minute running through that oxygen concentrator. So with a small amount of oxygen, this child's gone from being severely hypoxic to being well saturated. So I just wanted you to see that so that we can keep this in perspective. Most children will do very well with just oxygen. So the indications, I think, for CPAP or high flow, I'll talk about how they're different in a little while, but CPAP and high flow are two alternative ways of giving more respiratory support than standard flow oxygen. And I think the indications, for example, in children with pneumonia or sepsis or other illnesses, then you should give oxygen if the saturation is less than 92%. But if this child's still hypoxic, if they're still quite hypoxic, the saturation is less than 90%, or they've got severe respiratory distress, then often you can just give more oxygen. You go from 2 litres to 4 litres of oxygen, and that will correct the hypoxemia. But if they're still hypoxic after that, or they've got severe respiratory distress, then you need to think about using high flow or CPAP. So the indications for CPAP or high flow are severe respiratory distress or hypoxemia despite your best effort at oxygen therapy, and sometimes some other maneuvers as well, which I'll talk a bit about later. The thing is, before you go to CPAP, I think it's really useful to think about why a child might still be hypoxic despite oxygen. I won't perhaps go through all of these, but firstly, you need to check that the oxygen's flowing. We take it for granted that the oxygen will flow, but it's not always the case. So you can put the oxygen tubing in a beaker of water and watch for the bubbling. That's easy. Check that the oxygen tubing's not leaking, that you've actually got a good flow of oxygen to the patient, and check that the nasal catheter or the nasal prongs are fitted correctly to the patient and they're not blocked. You should also, if you're giving oxygen through a concentrator, check that the concentration of oxygen being delivered is adequate, and you can use an oxygen analyzer to do that. I'll show you one of them towards the end. You should check some things about the patient. So, for example, if the child's got a pleural effusion, then maybe that's why they're hypoxic. Or if they've got a pneumothorax, maybe that's why they're hypoxic. And you can check those things clinically. Or if they've got bronchospasm, so listen to hear if the child's got wheeze. All of those things might lead a child to not be responding to oxygen. Or check if they've got cyanotic congenital heart disease, if they've got, or congestive heart failure. Check for signs of heart failure. Also check if the child's breathing adequately. Some children have ventilatory failure. That is, they're breathing too slowly or too shallowly because they've got a central nervous system problem or they've got severe respiratory failure. So if they're not breathing adequately, then they won't, oxygen may not work. They've got to be taking adequate breaths. And then if none of those things are present, then just increase the oxygen flow to 4 litres per minute for infants or up to 8 litres for older children. That's the most you can do with standard flow oxygen. If that fails, then you really need to be starting CPAP or high flow. And I think the indications I've talked about the indications in children for CPAP, but in neonates, the indications are a little bit, I think, broader. And that is, in neonates who've got respiratory distress syndrome, then you should give standard flow oxygen if the saturation is less than 90, and aim to keep the saturation somewhere between 88 and 95%, but not higher. Not higher because of the risk of retinopathy of prematurity. So we aim to keep the saturation in the low 90s. But if the child's still hypoxic or they still have severe respiratory distress or they've got apnea, then you should try CPAP or high flow, whatever you've got. And the benefits of CPAP in neonatal respiratory distress are very well defined now. It improves oxygenation by recruiting alveoli. You can often use a lower fraction of inspired oxygen, so the child's not exposed to as much oxygen, but they're exposed to the positive distending pressures of CPAP. It certainly reduces the risk of apnea. If you've got a child who's having a preterm neonate who's having regular apneas, then giving CPAP can be the stimulation the child needs to continue to breathe. And as I said, it reduces the risk of retinopathy in very low birth weight babies because you're using a lower fraction of inspired oxygen, generally speaking. Sometimes babies can be in 25% oxygen and on a CPAP of 5, very low birth weight babies on a CPAP of 5, and they can do better than a baby who's on 1 litre per minute of 100% oxygen with saturations that are equal or higher. So it's CPAP is extremely useful for very low birth weight babies, and there's many of you will know, but there's a UNICEF program now which is delivering CPAP machines, which I'll talk about shortly, to many of the provincial hospitals, and so we need to get really good at being able to use CPAP. This is the Diamedica machine that is being introduced in many hospitals. It's a similar machine to the grey one that we previously had used more in children than neonates, but most of these are going to be delivered to special care nurseries and neonatal units in provincial level hospitals. I'll talk quite a bit about how these work, but there are oxygen concentrator that obviously extracts atmospheric air, that removes the nitrogen, and it produces both oxygen and produces air. And using this type of machine, you can blend the oxygen, which means that you don't have to give 100% oxygen to preterm neonates, but using the air, there's two outlets, and in most concentrators, there's usually an oxygen outlet and another oxygen outlet, or they just have one, and that's just an oxygen outlet. But in this type of concentrator, they have both an oxygen outlet and an air outlet. And the air outlet produces gas flow with a fraction of inspired oxygen the same as air, so 21%. And the oxygen outlet produces gas flow that is the same as what the concentrator does, which is around about 93%, if you like. A well-functioning concentrator would be somewhat more than 90%. And by blending the two of these flows, by blending the oxygen and the air, you can titrate the fraction of inspired oxygen that babies receive. So that's the key feature of these oxygen concentrators that enable you to give a lower fraction of inspired oxygen with a higher flow. So these devices have been around for over a decade and been used in many countries for neonatal care and also for the care of children with pneumonia or bronchiolitis or sepsis or other conditions. There are some other devices that produce bubble-CPAP. I'll explain what bubble-CPAP is shortly, but there are other devices that produce bubble-CPAP, which I'll briefly describe, but not in much detail because we're going to be using these Diamedica CPAP concentrators mostly. But the Fisher and Paykel bubble-CPAP machine is a good device, but I'll show you a picture of that just for your familiarity. And I won't talk too much about other methods of CPAP, except to say that, of course, you can give CPAP using a mechanical ventilator, or you can give CPAP using a CPAP driver. So usually this is the way CPAP's given for adults, certainly adults, using a CPAP driver. You've probably heard of the CPAP machines, and most CPAP machines are CPAP drivers that generate positive end expiratory pressure using a tight-fitting face mask, which can be used in children. Of course, you can use it in children. It's just, I would say it's a bit harder to manage those children in terms of their younger children don't always like a tight-fitting face mask, whereas these Diamedica machines, they provide CPAP using a different sort of a gentler interface with the patient, I would say. I will talk a bit about high-flow nasal cannula oxygen therapy because it's an alternative to CPAP, and there are some high-flow machines in PNG. They were mostly given during COVID by UNICEF or one of the other agencies, and it's useful to know about high flow because it is a good alternative to CPAP, especially I think for older children, like beyond the neonatal period. I think we should stick with these CPAP machines, the Diamedica ones, because there's a lot being distributed around the country at the moment. But for older children, the Fisher and Paykel high flow device might be an effective device. There's another device called an Airvo that produces high flow nasal cannula oxygen therapy. And there are some of those machines available, but not so many. So I won't talk too much about that, except to show you a picture of them shortly. Any CPAP machine has some basic components, and I think it's important that we all understand what those components are. Firstly, you need a source of gas flow, and if it's a ventilator, then the ventilator is a source of the gas flow. If it's a CPAP driver, a CPAP machine, then the CPAP is the source of gas flow. In the oxygen concentrators, these Diamedica machines, it's the grey one, not the black one I showed you before. The concentrator is the source of gas flow, and that produces both as I said, the oxygen concentrator produces both oxygen and air, and there's one flow meter that produces oxygen and one flow meter that produces air. There are other methods of gas flow production in other types of CPAP machines. You always need an oxygen source. I mean, in a CPAP machine, or almost always, and that can be in an oxygen concentrator. Then the oxygen concentrator itself is the oxygen source. If you're using, say, a CPAP driver or a ventilator, then you need an additional source of oxygen. And so they're not as efficient because you have to use often high flow oxygen using another source, using a cylinder, and they can run out quite quickly. So the oxygen concentrators are much more efficient ways to deliver oxygen and air in a blended way to provide CPAP. You need a patient interface with a relatively airtight seal, and they can be, as I said, in adult CPAP. Of course, you use a fairly tight fitting but soft face mask. It's got a cushion on it that fits the face reasonably well in most people. In children, we've been using nasal prongs, different sorts of nasal prongs, and I'll show you the three types that have been used, and I'll show you the ones that are being used mostly with these Diamedica machines. You need a circuit that is an inspiratory limb. A circuit is like a circuit of tubing, and there's an inspiratory limb, right, that has that goes to the patient. So from the gas flow to the patient, the inspiratory limb, and then you need an expiratory limb that comes from the patient to the gas to the device that generates the CPAP. All right, and so that's what a circuit is. So we need to get used to the terminology of a circuit. It's got both an inspiratory limb and an expiratory limb. The inspiratory limb goes to the patient. The expiratory limb goes in a bubble CPAP device. It goes into a bottle that is filled with water, and the amount of distance that the tubing is underneath the water is the amount of CPAP that will be given. So if it's 5 centimeters underneath the water, the surface of the water in the bottle, then it will be 5 centimeters of water of CPAP. That's usually, most children are on somewhere between 5 and 10 centimeters of water of CPAP, 5 and 10 centimeters of CPAP. And that means that the tubing, the distal end of the expiratory limb, is 5 or 10 centimeters underneath the water. And that's what generates the CPAP effect, coming from the expiratory limb. And if it's if there's a fairly tight-fitting nasal interface, then as the child breathes out, they'll generate bubbles in the water, and that will generate the CPAP. So that's the effect of CPAP. It's an underwater seal, and a bit like a pleural drain, but for different reasons. It's generating CPAP against the expiratory gas flow of the patient. And the last thing any CPAP machine needs is a source of humidification. And when you're using low flow oxygen, you don't need humidification because the amount of air that the child entrains in the rest of their breathing the oxygen goes through the nasal passages, and that humidifies the air well. Adds water. Humidification is adding water, and that's what our nasal passages do all the time to the air we're breathing in. But if you're giving higher flow oxygen or an air oxygen mix, then you'll get very dry nasal secretions, and sometimes that can lead to like a nasal erosion or a mucosal erosion or some bleeding or ulceration of the nose, or just can lead to the nasal secretions getting really thick and blocked up, and the child will be will have worse respiratory distress. So a humidification source is very important. So all CPAP machines have each of these components: a source of gas flow, an oxygen source, a patient interface, a circuit, with an inspiratory and expiratory limb and a humidification source. That's all they need. And different machines have different ways of providing that. This is the Fisher and Paykel machine mostly for neonates, and it's been used in some Pacific countries and used very well in Fiji. It's certainly used in Australia in many neonatal units around Australia, and it has all these things that we've talked about. So it has a source of gas flow here. It has a source of oxygen, which is in the Fisher and Paykel machine. It's a blended source of oxygen, so you still have to have an oxygen cylinder to generate some oxygen through the machine. It's got a humidifier here. It's a heated humidifier. And then it's got an inspiratory limb and an expiratory limb going from the patient, and that goes to a tubing that goes underneath the water in this bottle and goes underneath the water. And if the tubing is 3 centimeters under the water, then it's 3 centimeters of CPAP. If it's 7 centimeters under the water, then it's 7 centimeters of CPAP. And you can adjust the tubing up and down depending on the CPAP you're giving. That's the Fisher and Paykel machine. And it's an elegant machine, but you still need an oxygen source. Whereas with the oxygen concentrators, your oxygen source is the concentrator. Now, this is the first type of bubble CPAP that was used using these concentrators. Just used some oxygen tubing and standard nasal prongs. Now, the benefit of this is they're easy to make and they're readily available. Nasal prongs, all you do is cut them down so you've got an inspiratory limb and an expiratory limb. I won't go through that too much. And then you put the expiratory limb right underneath the water and you tie off the inspiratory limb so that you tie off the connection between the expiratory limb and the inspiratory limb. So you've got the gas flowing from the machine into the patient, and then as the patient breathes out, the air they breathe out is bubbled underneath the water. So if it's 5 centimeters under the water, then they've got 5 centimeters of CPAP. They're still getting all the oxygen in, or the gas flow in. They can breathe out through their mouth, or they're also breathing out through the expiratory limb, and that goes under the water. Now, this is it was an efficient and cheap way of providing CPAP, but there are some problems with this, and that is that the tubing itself is quite narrow, and sometimes instead of the patient's breathing efforts making CPAP, instead of that causing the bubbling can simply be caused by the fact that the tubing is quite narrow, so that there's high resistance in the tubing. For CPAP to be effective, you need low resistance tubing. That is broader, a wider diameter tubing. And so this patient configuration using this patient interface using just standard flow, a standard oxygen cannula and the modification of that is effective sometimes, but other times it leads to high resistance and it leads to what we call auto bubbling, which means that the bubbling you see is not because of not because of any CPAP being administered. It's simply because the tubing's too narrow. So I don't think this is an ideal way to give it anymore, because there are better ways. The next way we tried was using these oxygen prongs called OptiFlow prongs, and these are low resistance tubing. They enable high flows to go through without auto bubbling, and they're generally pretty good. And they can be attached just like oxygen tubing. On the other hand, they weren't designed for this type of machine, and they're a bit expensive. And so these are not currently being used, but they're still quite effective if you have any of these OptiFlow prongs. They require a bit of configuration. This is the inspiratory limb going to the patient. This is the expiratory limb going to the bubbling, and you have to connect the OptiFlow prongs up to the Y connector between the inspiratory and expiratory limb. So it's a little bit more complicated to put together. And as I said, they weren't exactly designed for this type of a device. You can see that the tubing is wide bore tubing, so it's very low resistance tubing. And these OptiFlow prongs, they take very high flows, so they're also low resistance tubing, even though they look only just a bit wider than oxygen prongs. They're softer and they're wider, but probably also not ideal for the reasons I've mentioned. This was actually the first way we tried CPAP in older infants. So this is a 1.5-month-old baby, the first baby to get CPAP in PNG. And you can see that the tubing is wide bore all the way. And these are soft nasal prongs that are large enough to go in the nostrils, and this is what's currently being used in the Diamedica machines for neonates, and they can be useful for older children as well. They still need to be attached well to the child's head, and there's various ways you can do that with some strapping that you can put on. That's probably the hardest thing, is to keep them in place. But they're low resistance tubing, they're nice and soft, so they're not likely to cause major mucosal trauma, and they're good for neonates and for other infants. So this is a useful thing. These days now we've got these Diamedica machines. They work on the same principle, and you can see here some twins that are on these same nasal interfaces, and twin very low birth weight babies that are receiving CPAP to support their respiration. So I just wanted to go back a step and just say how to sort of get started with a CPAP machine. And the first thing is just standard things. You need to position the concentrator so that it's about a foot or 30 centimeters away from walls, and keep it out of the direct sunlight. You want it away from walls or curtains so that the gas can flow into the machine. It's the standard way we look after an oxygen concentrator. Obviously, plug the power cord in, turn on the concentrator. Whenever you turn on an oxygen concentrator, always have the oxygen or the gas flow dialed up. You have to have it turned on. If you don't have that, then the machine ends up generating gas flow, and there's nowhere for it to go, because the flow meters are turned off. If the flow meters are turned off, then there's a buildup of pressure inside the machine. So all you have to do is turn the oxygen and the airflow on before you actually turn the power on. That's all. Then gas will flow immediately from the gas outlet. And as you know, there's an orange light that comes on if there's sufficient that comes on when you turn the machine on, and that goes off when there's sufficient oxygen concentration reached, and that's usually within 5 to 10 minutes. I'll show you how you can check that towards the end. You fill the water bottle there's a level indicated on the water bottle, and you fill that with cool boiled water. So you want to use sterile water or cool boiled, not hot water, but cool boiled water, and screw on the lid back on, of course. You connect the inspiratory limb of the circuit to the gas flow outlet, so the gas flow outlet on the concentrator, and then the expiratory limb of the circuit's connected to the bottle, and so that means the child can exhale into the bottle, and that will generate the CPAP. And then you dial the level of whatever the CPAP is required. You could start at 7 or 5 centimeters of water. Before you connect the patient interface, like the nasal prongs to the patient, then always check that there's no bubbling. You shouldn't see bubbling before you actually connect it up to the patient. If you do see bubbling, that means there's auto bubbling, and that means there's a blockage in the circuit somewhere, like there's too much resistance in the circuit or something like that. So usually with the interfaces, the last two interfaces, the OptiFlow prongs and the soft nasal prongs, the wider bore prongs, you don't see auto bubbling, but it's just important to check that you don't see bubbling until you've attached it to the patient's face. you should start to see bubbling when you attach it to the patient's face. So you connect the nasal interface to the child, and then you dial up the air and gas flow to see you want to see a constant stream of bubbles in the water. I'll just show you this video. So hang on, I'll move this across so you can see it. So you can see there the concentrator's on, and I think you can see the bubbling that's coming out, right? And that's on 3 liters or about 3 liters of oxygen and about 3 liters of air. And this baby had the Optiflow prongs on, and and is generating CPAP. Because you can see the bubbling, right? You have to be able to see the bubbling. If you can't see the bubbling, then there's no CPAP being delivered. If you can see the bubbling before you attach it to the baby's face, then there's auto bubbling. That's all. So you dial the flows up to whatever you get a steady stream of bubbling once you've connected it to the child. In an older child, like of 5 kilograms or more, I usually start with 5 liters per minute of oxygen and 5 liters of air. So you've got a total of 10 liters per minute. You can start with a bit lower, that's okay. And with the neonate, usually 2 liters of oxygen, 2 liters of air, or 3 and 3, that's okay. When you're giving 3 and 3 to a neonate, you're probably giving about 57% oxygen. It's not 50%, it's a bit more. 57% if you're giving 3 and 3 or 2 and 2. And that's quite a bit of oxygen to a preterm baby. So then you need to dial down the oxygen if the baby's doing better, if their respiratory distress resolves, if their oxygen saturation comes up to the right required level, like between 90 and 94% thereabouts. So for a preterm baby, you should continually monitor the saturation and reduce the oxygen flow rate if the saturation is good, if it's in the range you want. And you should aim for 90 to 94%. It's always good to record on a monitoring chart what flows you've dialed up and what fraction of oxygen, the FiO2, the fraction of inspired oxygen you're delivering. And as I said, you can determine that there's effective CPAP by looking for continuous bubbling in the bottle and also the clinical state of the child. If the child's respiratory distress settles, if their oxygen saturation improves, then you know you're delivering effective CPAP to this child. Right? So the key things are no auto bubbling before you put it on the child, and afterwards titrate the oxygen and air to the right, to seeing bubbling, the flows, to being able to see continuous bubbling, and look for the clinical state of the child and see that they're improving. Now, you need to have some way of troubleshooting, and not all children you put on CPAP will improve straight away, but usually they improve in the next hour or two. I usually wait for an hour or two, and what you usually see is that the respiratory rate will come down, the degree of respiratory distress will improve, the heart rate will often come down, the oxygen saturation will come up. If you have a situation where you haven't achieved that, then, and say the oxygen saturation is still low, then you can increase the CPAP level. If you started with a CPAP of 5, then you can go to 7 or go, from 7 to 10, and you can increase the gas flow. But you should always check that there's bubbles. If there's bubbles, you're giving effective CPAP, but maybe you're not giving quite enough. So if the saturation's low, you can increase the CPAP level or increase the oxygen flow. So you've got more, a higher fraction of inspired oxygen. If you don't see bubbles, then there's something wrong. You're not delivering effective CPAP. And that might be because there's too much of a leak around the nasal prongs. And so to overcome that, sometimes you'll refit the nasal prongs. Sometimes you'll need to increase the flow rate to see if you then get more bubbling, because it is dependent on the flow rate. It's dependent on the adequacy of the seal around the nostrils and also the flow rate. And sometimes you might want to increase the CPAP level to see if you can get more bubbles and the saturation to come up. I won't go through these other ones, but but you need to have a way of troubleshooting if CPAP's being effective, then over time you might want to reduce the CPAP. You might want to reduce the fraction of inspired oxygen. If the saturation is more than 90% and the child's improved to only have mild respiratory distress, then it may be time to reduce things. And if you've got saturation more than 90%, but still got severe respiratory distress, then usually the child just needs a higher CPAP level. They might not need more oxygen, but they need a higher CPAP level to see if that can reduce the degree of respiratory distress, their chest indrawing or their respiratory rate, etc. So you can titrate all of these things. You're essentially titrating the oxygen flow, the gas flow, and the CPAP level. And you titrate, I should just explain, you're titrating the CPAP level. I'll show you this. You're titrating the CPAP level using a dial on the bottle here. And the bottle dial can be dialed up to 5, 7, 10, or down to 3, or whatever you want. Right. So that's where you dial the CPAP level, and you dial the oxygen level through the oxygen flow meter, and you dial the air level through the air gas flow meter. The Diamedica machines also have if I can just show you, they have a way that you can compare, you can know the fraction of inspired oxygen you're delivering. The older machines have an algorithm that has, if you're giving, say, 5 of oxygen and 5 of air, then you're giving 57% oxygen. There's a table on the front of them, and we'll have to reproduce that in the new machines. If you're giving, say, if you're giving 5 of 5 of air and only 1 of oxygen, you're probably giving about 25 to 30. I just want to touch on some complications of CPAP. Well, firstly, someone's got there. So could you mind using your device? Okay. I just want to touch on some complications of CPAP. Firstly, it's not a complication, but it's like an absolute contraindication. If the child's not adequately breathing, if they're not ventilating adequately, making good respiratory effort, then usually CPAP will be of no effect at all. If the child's not adequately breathing, they need to be intubated and ventilated. They need to be mechanically ventilated, or they need bag mask ventilatory assistance or something. CPAP is just distending pressure that won't get a patient who's not breathing adequately to breathe adequately. It will improve respiratory distress, but it won't deal with the non-breathing patient. Sometimes with CPAP, you'll get some pressure areas, but again, it depends on the patient interface. If you're using a soft nasal interface, then it's usually pretty good. When a child's on CPAP or on high flow, you need to prevent gastric distension, because that can have an effect on breathing. If a child's stomach distends, then that puts pressure on their diaphragm. Then their diaphragm has to work more to inflate their lungs. And so gastric distension is a complication that you can just prevent using a nasogastric tube that is on free drainage, or you just leave it open to air or drain it regularly. And then very rarely, CPAP can cause an abrupt increase in pressure leading to a pneumothorax. That's very, very rare. I don't usually worry about it, except in a few patients that are more prone to pneumothorax, such as those who've got staphylococcal pneumonia, who might have pneumatoceles, or sometimes children who've got pneumocystis jirovecii pneumonia. They're prone to air leaks and pneumothoraces, and also children with asthma, of whom CPAP can help, but they're a bit more prone to pneumothoraces with or without CPAP. But they're just children to be a bit more alert to that a pneumothorax is possible. Okay, so that's all I want to say about CPAP, and I think there'll be more practical demonstrations of CPAP when the Diamedica machines are installed in nurseries, but it's useful to have an understanding of how CPAP works and how you get started. I wanted to talk about high flow nasal cannula oxygen therapy now, and just really describe the components. This is a Fisher and Paykel. I mean, the brand doesn't matter, but this is a high flow nasal cannula oxygen device, and it has many of the features of a CPAP machine. So it's got this is a blender, and a blender has a blender enables the oxygen and the air to be blended. And instead of giving 100% oxygen or just giving air, 21% oxygen, you can give somewhere in between. And this is a crucial part of high flow, the way high flow works. It needs to be blended and it needs to be humidified. And so this is the humidifier down here, and that's usually set at 37 degrees. And there needs to be a source of gas flow, which here is the oxygen flow, and that could be through a cylinder or even potentially through a concentrator. There needs to be a source of gas flow, both airflow and oxygen flow. And there needs to be some nasal prongs. So in the high flow nasal cannula oxygen therapy using this device, they use the OptiFlow prongs that I showed you before, and they're quite effective for infants and young children. Then there's some other ones for some different types for older children. When you're using high flow with these devices, you use 2 litres per kilo per minute for the first 10 kilos. And so that means a child who's 4 kilos will be on 8 litres per minute. A child of 5 kilos will be on 10 litres per minute. I'll explain what you do after that in older children. You humidify gas at 37 degrees, so it has to be plugged into electricity. And usually you watch the respiratory rate and the heart rate and the degree of chest indrawing and reduce and the oxygen saturation. And usually, if a child's responding properly to high flow, then all of those things or several of those things will improve. Their heart rate will reduce maybe 20%. Their respiratory rate might reduce by 20%. Their degree of chest indrawing will become better, and they'll need less oxygen. And that's how you gauge the effectiveness of high flow. And again, usually that happens within an hour or two of going on to high flow. Usually those vital signs will improve. High flow, the studies have shown that it generates about 4 to 8 centimeters of water of PEEP or a CPAP effect. Not always, and it depends. Unlike giving CPAP, it depends very much on whether the child's got their mouth open or closed, and how good the patient interface, the seal is around the nostrils. So it does depend on a lot of things. And for most children, you don't get much more than 4 centimeters of water of CPAP effect. So, but you get some, and the high flow alone can be useful. So I said that you use 2 litres per kilo per minute for the first 10 kilos. Every kilo after that, you should use 0.5 litres per minute. So a 4 kilo child, they'll get 8 litres per minute. As I said, a 6 kilo child will get 12 litres per minute. If a child's 14 kilos, then they get 2 litres per kilo for the first 10 kilos. So that's 20 litres per minute. And for the next 4 kilos, they get 0.5. So that's an extra 2 litres per minute. So it comes to 22. And all the effect of this is that as a child gets bigger, the gas flow they need doesn't increase in a linear way. It increases a little bit, but not in a linear way. So you don't have an adult who's like 60 kilos being on 120 litres per minute. That would be ridiculous. So if you think about, there are many hospitals around the world that use high flow for adults, and they usually run around about 50 or 60 litres per minute, not 2 litres per kilo all the way up to that high level. So if you're 22 kilos, then you get 2 liters per kilo per minute for the first 10 kilos, which is 20 liters. And then for the next 12 kilos, beyond 10 kilos, a 22 kilo child, they'll get half that, won't they? They'll get 0.5 times 12, which is 6. So they're only getting 26 liters. So you can see the rise in the flow that they receive is much less. And that reflects that lung volume is not linear with weight. It's non-linear. I won't go through that too much, but it's been well worked out. In high flow, you should aim to use the lowest FiO2, that's the fraction of inspired oxygen, to achieve whatever your oxygen saturation aim is. And so in a child who's got pneumonia, you might have an aim of an oxygen saturation more than 92%, and you then give high flow to achieve that. And so you give a 5 kilo child, you give 10 liters per minute, and you might start with 50% oxygen, a fraction of inspired oxygen of 0.5, and then you reduce that if the saturation's your target. If you can achieve 94 or 95%, then you might be able to reduce it to 40% oxygen. The main point about reducing the fraction of inspired oxygen is twofold. One is if you've got a preterm baby or a very low birth weight baby, you want to expose them to the minimum amount of oxygen, the minimum fraction of inspired oxygen, to reduce the risk of retinopathy of prematurity. And also, if you've got an older child who's who might have pneumonia or bronchiolitis, if you were to give 80 or 100% oxygen, you won't cause oxygen toxicity to the eyes, but you can mask what we call type 2 respiratory failure, where a child's not hypoxic, their oxygen saturation's okay, but they're just not breathing enough, and they'll become hypercarbic. That's type 1 respiratory failure is hypoxic respiratory failure, where the oxygen saturation is low. Type 2 respiratory failure is hypercapnic or hypercarbic respiratory failure, where the carbon dioxide level is high. And I've seen one child who received high flow at 100% oxygen for many hours, and people didn't recognize that his carbon dioxide level was well over 100, because he wasn't hypoxic, and because when you looked at him, he didn't look like he had severe respiratory distress. So it just can be, that's why in a child with pneumonia or bronchiolitis, an older child who's on high flow, you should try to titrate down the fraction of inspired oxygen. So you're using less oxygen, so the child's not exposed to as much oxygen, and you won't mask type 2 respiratory failure, while still achieving the oxygen aims that you have, with over 90% that you aim for. I said that there's another device that can give high flow. I won't talk too much about this because there's only a few of these, I think, in PNG. They're quite good compact devices. They have a gas flow generator. They have an inbuilt humidifier. They can give a flow rate between 5 and 45 liters per minute, and they have an inbuilt blender and an oxygen analyzer that tells you just what the fraction that you're giving is. And they cost about $2,000. So they're not cheap, but they are quite effective. They need obviously a electricity to run them, but they're quite useful. They also run off those OptiFlow prongs that I talked about before, but that's called the Airvo. But the alternative is to use this type. This is the Fisher and Paykel one, which is a bit more available. So I just want to briefly touch on when you're starting to do CPAP, there's a few things you need to be aware of. And one is in studies that have been done using CPAP in lower income or lower resource settings, when they've been done in a high dependency unit setting where there's a good number of nursing staff, when there's an area set aside for the most critically ill patients in a HDU or an ICU setting, then it's been very effective. When the CPAP's just been put on the ward and nurses have just been instructed on how to use it, and there's not good medical oversight, and the nurse-patient ratios are are very low, that is a lot of patients to minimal number of nurses, then the outcomes have not been very good. So when you're using CPAP, it should be in a HDU setting in the ward, so you have an area set aside for the most seriously ill patients. You have good monitoring by nurses. You're using a monitoring and response chart, the sort of chart I've shown you before, so you can track what's happening to the heart rate, the respiratory rate, the degree of respiratory distress, the oxygen saturation, all the vital signs, and you can record how much CPAP or high flow you're giving and the fraction of inspired oxygen. Ideally, you should have a one in that HDU area. Ideally, have a 1:4 nurse-patient ratio. That is 4 patients to 1 nurse. That's the sort of ratios of staff that have proved to be highly effective. And it's also that's proved to be highly effective in a HDU setting. And you need close monitoring of these things I've talked about, plus the complications. And I think these children need to be seen very regularly by nursing staff and very frequently by medical staff as well. And nurses and doctors need to be trained in how to use both the machines, how the indications for CPAP and for high flow, and how to troubleshoot, and how to look for complications, how to assess the effectiveness. Is it working for this child or is it not? Should we just go back to oxygen, or is it working, etc.? So lots of decisions to be made. It can be useful to have a respiratory distress score that you apply to a patient. And this is one of the types of scores that you can use. And it assesses a number of things. For example, there are 5 different parameters, and they can be classed as mild, moderate, or severe. And obviously, you're trying to get your patient in the mild category in all of these, but you can assess for hypoxaemia. So what's their oxygen saturation? Assess for their degree of chest wall indrawing. Assess for their respiratory sounds when you're listening to their lungs. Assess their respiratory rate and their heart rate. Very simple, all the things that you measure normally. But what you're doing is applying a score for each of those. Mild is 0, moderate is 1, severe is 2. And we found this quite useful in patients who are on high flow or CPAP, so that you can track their respiratory distress score over time. Again, you'll be recording all of those things anyway, and it can be useful to make it into a score that you can see, is the respiratory distress score improving or not improving? And so you have an objective assessment of whether or not the child's improved on CPAP or not improved on CPAP or high flow, whatever the patient's on. I mentioned before, sometimes it's very useful to know whether your oxygen concentrator, whether it's your Diamedica machine for giving CPAP or a standard oxygen concentrator, is actually giving the oxygen you want it to, right? And this is, many of you will have seen these. These are oxygen analyzers. It's not a pulse oximeter, it's an oxygen analyzer, and it's used to check the performance of your device. When you open them to air, then of course the fraction of inspired oxygen will be 21%. So that's this device, this oxygen analyzer is just open to air. There's some tubing there and it's open to air. And so it's 21%, and there's no flow of the no flow through the tubing. When you hook it up to an oxygen concentrator, this is hooked up to an oxygen concentrator, and that that's the concentrator is giving you, it's dialed up to 6.4 liters per minute, and the concentrator is making 95.9 or nearly 96% oxygen. So it's running very well. And this can give you confidence that your oxygen concentrator is delivering the oxygen you want it to deliver. Okay. There are some technical problems you can run into when you're giving CPAP, and I just wanted to run through a few of those and the solutions for them, because in using CPAP in many studies, we've found lots of different problems can arise, and there are solutions. So sometimes the circuits split if you wash them multiple times, or they're washed in sort of too heavy bleach, and that can lead to air leaks along the circuit. And if you have an air leak in a CPAP circuit, then it won't deliver CPAP. So you need to check the circuits regularly and make sure people don't step on them, so that they split. The circuits these days are better than what they were. They were sort of a harder plastic before, and now they're quite soft plastic. But sometimes when you're running an oxygen concentrator for delivering CPAP, you're running it at high flow rates, and that runs the concentrator to the limits of its performance. And that can sometimes lead to fatigue. The concentrator can become fatigued. So you need to do two things. One, don't run the concentrator to its limit of performance. And aim not to run it at 10 litres per minute, because that will lead to it being fatigued. Usually you don't need to, maybe 8 litres per minute or 6 litres per minute in total, 5 and 5 or whatever. But usually don't aim to run it at the maximum performance, because it will just in time lead to fatigue. And also check your concentrator to see that the oxygen outflow is delivering 93 or 95% oxygen, what you aim it to be. Some humidifiers are not very effective, and that can lead to nasal congestion or nasal drying of nasal secretions. And so you need to have an effective humidifier to the CPAP machine. These days, the Diamedica machines have an inbuilt humidifier, and which is pretty good. It's a moderately effective humidifier. You need to keep the environment free of dust if you can, and the concentrators have two filters, so they will filter the air as it's coming in. But ideally, it's good to keep the environment free of dust. In terms of the patients, there are certain patients that CPAP is very good for, or high flow is good for, and then there are certain patients that it will help, but unless you address the other problems, the comorbidities the child has, then you may be disappointed with the result of CPAP or high flow. And the things I'm thinking about, if you've got a child with severe malnutrition or anemia, or they've got HIV, or they've got some other alternative diagnosis like congenital heart disease, of course CPAP can still work, but it may not be as effective because they've got comorbidities that need to be addressed. Obviously, there's some other logistical problems, and I think what a hospital needs, if they're going to deliver CPAP, is they need to have like training for staff in how to do it. They need to have a guideline in indications for use and troubleshooting, etc. They need to have daily ward rounds. I mean, obviously at least every day, and I think any hospital that's giving CPAP more than once a day, and the registrars need to be around and available 24 hours a day. They have to be available to come and see these patients. You need to have monitoring and response charts so that if a child's going into the red zone, then you do something about it. You call someone else. These are all things that in a HDU setting, in an ICU, then you need to set up these mechanisms. It's a system-wide issue. You need good systems. You need good training, and it's ideal if you have identify a nurse or a doctor who's very familiar with the concentrators, the nasal prongs, the circuits, the spare parts, etc., and how to manage them, how to look after them. You need quite a bit of training in this, and designate someone who can do that. It's good if you can engage with your biomedical technician, because they can be quite helpful too, and they need to learn how to do regular maintenance as required on the concentrators. Most of the concentrators don't need too much maintenance. They need cleaning, and they need the filters changed, which is easy to do. You can learn how to do that. I'm nearly finished, but I was going to just say there's if you've got a child who's very hypoxic and they may be on CPAP or they might just be on oxygen, sometimes it can be useful to nurse them prone. And we learnt this, as many of you know, during COVID, and in children who've got severe lung disease, pneumonia, or other forms of lung disease, they can often be better oxygenated if they're being nurse prone. And so I have children that are on CPAP or even on ventilators that we nurse prone, that is face down, not face down, but like in a prone position with their face turned to the side on CPAP. Now, that won't be acceptable to many children. They'll be too irritable, but it's surprising how many are happy to be nurse prone for several hours, and that can improve their oxygen saturations. Don't want to overstate this, and it has to be, ideally should be done in an ICU or a HDU setting where you've got staff who can manage the patient. But I hope that all of you have learned how to do prone positioning in patients. It's not just turning them over on their tummy. It involves putting pillows in to elevate their chest so that their chest can be open and take good breaths in, and involves putting them in a very, very comfortable position. So I've had lots of children that have benefited from being nurse prone and be on CPAP at the same time. All right, that's all. So I've talked about this talk has been mostly about CPAP using devices that have become available. It's especially in the neonatal units, and a bit about high flow, which might become a bit more available for older children in the future, or you can use CPAP in older children if you've got the right interface. That's all I was going to say today about this, but I think this is an important thing for us to learn about how to give respiratory support for those relatively small proportion of children that need something a bit more than just standard flow oxygen. I'm going to stop the recording now, and I'm happy to answer any questions that you might have.